You are listening to the Loop Podcast, a project in plastic surgery innovation.
Hello and welcome back to the Loop Podcast. I'm Bassiri-Tehrani, one of the core hosts. I'll be joined today with my older brother, Dr. Michael Bassiri-Tehrani, and today we'll be talking about rhinoplasty. My brother Michael graduated Stony Brook out in Long Island and did his ENT residency at New York Eye and Ear Infirmary at Mount Sinai. He then did a fellowship in facial plastic surgery out at USC and Lasky Clinic. Now he's in private practice in the Upper East Side. Welcome to the Loop Podcast.
Thank you for having me.
Glad to have you on. So let's start off with why you're so interested in rhinoplasty. I think that's your favorite operation, right?
Yeah, I do love doing it. Basically, for anyone who doesn't know, facial plastic surgery is a subspecialty within ear, nose, and throat, or otolaryngology. So training in otolaryngology, we do get facial plastic surgery, but we also train in a lot of the nasal airway obstruction and sinus surgery. So we are very comfortable in the nose and doing endoscopic surgery in the nose. So it kind of goes hand in hand to be able to do some cosmetic work there as well. So I find it very creative, challenging, and stimulating.
So how do you and other ENTs in general approach rhinoplasty as opposed to, let's say, a plastic surgeon? Are there techniques that are different or different approaches?
It's interesting. I mean, rhinoplasty was kind of developed by both plastic surgery and ENT. The way we approach rhinoplasty is because we see a lot of nasal airway obstructions throughout our training and even afterwards, making sure that everything is done in a stable fashion that will prevent nasal collapse or structural obstructions in the future is very important. So basically, the thing about rhinoplasty is there's an infinite number of techniques and combinations of techniques. Some of them go well together, some of them might not. So that's the challenge in figuring out kind of what you have to do to get the result you want.
So how do you determine, I guess, which techniques would you use? I guess walk me through your patient assessment, and are some of those techniques kind of running in your head when you walk in a room and you see a patient and you start to evaluate?
Yeah, so I mean, there's a definite go-to combination workhorse techniques, workhorse moves that work very well for a lot of patients, and then you have to modify them for revision rhinoplasty. Patient assessment is super important. Communication with the patient is super important, and listening to them, hearing what they want and what they really need. So standard facial analysis is important, but not only just relying on that, but looking at the patient and seeing if those numbers and quote unquote rules actually apply to the patient. A lot of times you have to deviate from those rules slightly in order to get proper harmony for that patient's particular facial situation. And then explaining that to the patient so that they understand kind of what's unique about them and their face.
Were there any, like, I guess, fads historically that were in style, I guess, to using a certain type of osteotome or
right?
Is so hot right now.
Yeah, so if you actually, it's fascinating to read old textbooks on rhinoplasty. A lot of things have changed. A lot of things have not. There's the rhinoplasty initially started out as more favorably done in a closed approach, and now it's more open, and that's how a lot of people train. But it goes back to closed, and it depends on kind of who trains you and what you're most comfortable with. Certain techniques have come in and out. If you look at some very old textbooks from the 50s, people used osteotomes. Then there'd be reports after that of how the osteotome isn't precise enough. So we went to Joseph saw to do osteotomies. Then there were some irregularities with that, so people went back to the osteotome. Now people are playing around with piezo ultrasonic saws, which is kind of like a ultrasound Joseph saw. And now, because of COVID and also because of other reasons, people are going back to osteotome to prevent less spraying. So certain methods are tried and true, and we know that they achieve a certain result. And it's also, because it's cosmetic surgery, trying something new and cutting edge isn't as exciting as maybe some other fields of surgery where, you really don't want any kind of surprises.
Yeah, no surprises. Actually, you brought up different fads, but dorsal preservation is actually over 100 years old. We won't get into that today, but what was once old is now new again. But moving on to, I guess, some of the newer techniques like digital imaging, so like Vectra and Chrysalix. Do you use that? Do you find that helpful in talking to your patients or evaluating your patients?
Totally. So patient communication is really key. That's very good tool, some sort of imaging where you can communicate with the patient about the changes they want. Many people don't know exactly the changes they want. Many people don't know what a good nose may even look like. They kind of rely on their friends or photos in magazines, or sometimes just look at photos and say, well, I don't know, is that good, is that bad? Being able to show them what their nose looks like on a photo of themselves, or what it could potentially look like with certain changes using Photoshop, or there's other modalities, really lets you pinpoint kind of their pain points and where things are bothering them and how happy they would be. Oftentimes you'd be surprised, some people might not like, let's say, a more concave nasal bridge versus a more neutral bridge. And the specifics of that really don't come out until you show them what the differences can look like. That being said, a lot of times, you actually learn about the patient as you're doing this. So you can see that some patients can be very hyper focused on minimal changes, and you'll pick that up in this kind of 15, 20 minute, 30-minute interaction with them. And then also, you'll see patients, some of them will come back multiple times to just change things a millimeter or so in the picture. And these are all clues that this might be a patient that might not be happy with future result, no matter how accurate or good you may think it was.
Yeah, that's a good point. One of our attendings in Chicago, Dr. Jeremy Warner, explained how he uses digital imaging, but he also mentions to the patient that they will not look perfect. And he not only documents it, he counsels them a lot. So I wonder if there's any other things that you pay attention to that they actually say or mention that you kind of have like the red flags, something like that.
People using the word perfect a lot, or 100% symmetric, especially if things aren't very deviated, I think are important. People who come in with a large amount of photographs from magazines or pictures of themselves in all different angles, I mean a lot, like almost like a binder's worth, that might be something that could signal that this is a little out of proportion for the maybe deformity or the shape that's bothering them. So it's just really important to get a feel for it. And just sitting there and communicating with them, looking at a shared computer screen, can kind of remove some of the stress involved, and really gets people to open up. Now, I do 2D imaging where I will use basically a flat 2D picture and with a blue background, and move and change the shape of the nose. 3D modalities do exist. Some popular ones are Vectra and Crystal-X. Vectra actually takes simultaneous photos from different angles and puts the images together in a very accurate way, so that you can have now a 3D rendering that can be manipulated on a computer screen. And we did some work with that in fellowship in Beverly Hills, and you could even have 3D printed heads that look lifelike and very creepy, almost like decapitated looking heads, show up in the mail. And they're cool and they're fun, but I think it gets people hung up on little details that may or may not be controllable. What you really want to figure out is certain key things: how much rotation, how much projection, or what type of bridge that would interest the patient, and rather than fixating on this really cool looking spinning thing. There's certainly a role for it, and I think it's going to continue to expand, especially with now some maybe preoperative models and guides that are used. But any fad, it might just be like a gimmick or something cool right now, and only time will tell how much sticks around.
What about like CT imaging for you?
Very good. CT, it's not something I routinely get for patients who are considering cosmetic surgery. Occasionally, you can consider it if a patient's having sinus symptoms, for example, or if you suspect something farther back, for example, posterior septal deviations. That might be a good way to assess it. Having ear, nose, and throat background, we routinely use flexible fiber optic scopes. We have them in the office. So it's very easy to get an assessment of both the posterior effect of the nose, and if there's any deep deviations that might not be appreciated on an anterior speculum exam, but also lets us look into the nasopharynx. So another area that can block nasal airway is nasopharynx. What if the adenoids are enlarged because of some sort of immune deficiency or some sort of mass? These are things that we want to make sure they're not there, in addition to just making sure that the nose doesn't have any structural changes to it.
And so how does the nasal function affect your plan of operation, or your sequence of how you're going to plan things out in the OR?
As far as the sequence goes, it depends. If the nose is very crooked or very deviated, and we know that there's a functional component and the patient needs to breathe better, we just anticipate maybe taking certain size grafts from the nasal septum in order to rebuild the mid-vault and open the internal nasal valve. It might lead us to do a more open approach, especially if things are very crooked. So open rhinoplasty is introducing a columellar incision, which allows us to elevate the dorsal skin and really look down on top of all the nasal structures without kind of pulling them and distorting them through the nostrils. So really those are the two kind of approaches, is closed and open. And for really difficult functional cases, you almost have to, or you should really consider doing it open, or I do.
Got it. So, being a functional rhinoplasty surgeon, we need to, I guess, think about all the different points of obstruction. Like, I guess one of the most important places that airway obstruction can happen is the internal nasal valve. And so, historically, spreader flaps or spreader grafts are used. What are your thoughts on that? One versus the other, or doing it open versus closed, and your approach to, I guess, placing those grafts?
Right. So I think this is an important thing that people tend to kind of gloss over. When you take down a dorsal hump, you are, in essence, reducing the insertion of the upper lateral cartilages to the superior septum. And depending on how much you resect or how much you detach those upper lateral cartilages, you will have some valve collapse. And at the very least, reconstituting the midwall, reconstituting the internal nasal valve with some suturing, I think is important. Now, if the caudal aspect of the upper lateral cartilages is intact and supported by the septum, then you may not need to do as much. But once you separate those out, they have a tendency to collapse and scar down over time. And it may not be immediately, it could be years, but they'll eventually find their way to an ear, nose, and throat doctor, and patients will complain about breathing. And here's somebody who's now had their internal nasal valve manipulated and now collapsed, who wants a breathing surgery. So repairing that involves at least reestablishing the connection of the upper lateral cartilages to the septum, pulling them up, suturing them, oftentimes using spreader grafts. So cartilage harvested from either the nasal septum or conchal cartilage from the ear to kind of take up that space. If there's any deviations in the septum, using that cartilage also can help straighten or correct any mid-vault deficiencies on one side.
Nice. And so, what about external nasal valve now?
So external nasal valve, when we refer to external nasal valve, it's more like the nostrils and whether the nostrils are pinched or collapsing. There's two types of external nasal valve, really, dynamic and static. Static is the nostrils are basically like thin slits. For whatever reason, there's not a lot of support there, or there's maybe some scarring that reduces the inlet of the nasal valve in that area, whether they're breathing or not. So that's static. Dynamic is maybe it's open, but the lower lateral cartilages are weak, maybe they're malpositioned, and there's a loss of support that when you breathe in, because of Bernoulli effect, you have a collapse, and it could be just on one side, could be on both sides, and the nose pinches in almost and could even close. So repairing that involves supporting that weak cartilage with cartilage grafts, and there's different varieties, batten grafts, lower lateral crural strut grafts. Sometimes the lower lateral cartilages are malpositioned or cephalically positioned, meaning that they're kind of pointing up instead of out diagonally, and you get a loss of support in the lateral part of the ala. So repositioning them is another option, which can be a little aggressive, but certainly something to consider.
So, what about, I'll give you a really kind of a complicated scenario here. What if you have somebody who has a bulbous or boxy tip and you need to do a cephalic trim? Are you going to leave a little bit more cartilage on the lower lat, or reinforce the little that you leave? Or how do you approach that?
Good question. So first of all, a complete strip technique is kind of what a lot of people are doing now, which in the past people would actually cut the cartilages and overlay them, or cut them and leave them, and that creates potential for weakness and collapse in the area. So nowadays it seems like people are leaving more cartilage intact, The amount that you leave intact, it depends on a couple of things. One, how strong and stable that cartilage is, if it's bowing or bending. But cutting it and overlaying it, as long as it's secure, is fine. So there's a variety of size recommendations and leaving 6 to 8 millimeters,
It's the
6 to 8 millimeters intact. But it's not a numbers thing necessarily. Our father's an engineer, so if you like, any material has its own structural integrity, whether you're using steel or plywood. There's only a certain amount of force that it can take. Now, everyone's cartilage is very different. So in a pre-op assessment, palpating the nasal tip, pushing it down, seeing how much tip support there are, it's very important to assess that cartilage. Once you open the nose or once you deliver the tip and you actually see the cartilage and you're manipulating it, you have a better idea of what's going on and where the weakness is, and whether you can put an overlay graft or if you're going to put like a lower lateral strut graft. And the other factor is you want to make sure that the cartilage is kind of straight and not curving out or curving in. If it curves in, you get this concavity of the nasal ale, and that can cause valve collapse in the post-op period. If it's bowing out, it can cause bulbous tip. So really supporting it with grafts to flatten it out and straighten it. You can put stitches in to flatten it and straighten it. And the other way is to kind of like a suspension bridge, tether it and basically suture the tip to a strong caudal septal extension graft as a point, and then use dome sutures to really make that cartilage taut, like you're pulling on a rope. And that tension is another argument that you don't necessarily need the cartilage to be thick or strong. It just needs to be on some tension and it will straighten out.
Got it. Okay, cool. All right, so moving on to the other points of airway obstruction. The inferior turbinate, sometimes patients have inferior turbinate hypertrophy. What are the different ways of addressing that? And what happens if you go a little too far?
So inferior nasal turbinates, from the word turbine or spin, I mean, basically these structures are spinning the air so that you have nice laminar flow from the front of your nose to the back. They do serve a purpose of humidifying the air and also creating the sensation of breathing. So if you go and just take these things out, which was done in the past, you get what can be called empty nose syndrome, and patients can have, it is difficult and annoying problem to fix. Essentially, patient's nasal airway is wide open. You can drive a truck through it, but they don't feel that the air is going through because there's not enough resistance in the system. And they don't feel the cold air hitting their turbinates like they would normally. So these things are important. Also, they're part of the nasal cycle. So throughout the day, throughout every 6 to 8 hours or so, one of the nasal turbinates will swell up. It has erectile tissue, and it will fill up, and the contralateral side will kind of collapse. And no one really knows why this happens, but it switches from left to right. And patients will always tell you about this as if they've discovered something. But the truth is, it's actually part of normal physiology. Some people think it's because of toxins, to remove toxins from the nose one side at a time, so you're still able to breathe through the other side. I've read older textbooks that it was thought that it keeps us from getting pressure ulcers. So while you're sleeping, one side's breathing, and then it switches and it forces you to kind of turn your body to the other side so you can breathe. Again, it's not something you want to completely eliminate just because we don't know really exactly why it's there. So the techniques are, there is a bony component of this outgrowth, and it can be outfractured simply with like a Goldman bar, Boise elevator, or long speculum. If you want to take out some of the bulk, essentially, there's so many different ways that either none of them work or all of them work. So you can do radio frequency, people bipolar them, so various energy-based things to scar and shrink them. Some of these can be done in the office. Other techniques are to introduce a microdebrider in a submucosal pocket, and that will be like a submucous resection. It kind of debulks, scars the erectile tissue so it can't balloon out so much. And then, the most aggressive would be to elevate a submucous flap off the bone and actually trim some of the bone and trim some of the bulk of the head of the turbinate and kind of redrape the flap. That would be a more aggressive technique, which, can be done. But I guess it depends on the patient's need and how much is going to be from the turbinate.
So let me ask you, so you bring up the nasal cycle, which I think is fascinating. I didn't really learn about that until you taught me that. But how do you know if a patient comes in with one side or unilateral inferior turbinate hypertrophy, whether that's just the nasal cycle going on and off, or is that something that is pathologic or physiologic, and maybe do you get that from history or?
You have to ask very targeted questions. You want to ask them, is there one side that is worse in general? And some people can tell you that. Sometimes just looking at the nose is not going to paint the picture that they're telling you. So patients will say that it's their right side, and you look in their nose and it's the septum might be deviated to the left for a little while and you're not sure, and then posteriorly it goes to the right, or there's nasal valve collapse that's making the breathing more difficult. So it's not just one thing, it's a combination of these things that can be causing the obstruction. When we do our exam, when we do fiber optic exams, typically we'll do nasal decongestant, either afrin or neosynephrine, and that will shrink the turbinates for the exam. And then at that time, you can ask the patient, are you still having trouble breathing, which side? And it'll kind of confirm, and it'll also help you see inside. What may have looked like a deviation may have just been increased swelling on one side.
All right. And so moving on to a different point is probably a very common point of airway obstruction is a septal deviation, whether it's from trauma or just in general having a deviated septum. What are your techniques for, I guess, doing a septal harvest or septoplasty?
Yeah, I think the septum is funny. I mean, a lot of people think they have a deviated nasal septum, and one of these old textbooks, my favorite line was, nasal septum can be deviated in ways that words cannot describe. So, oh, it's deviated to the left. Well, yes, it's deviated. It could be deviated to the left anteriorly, but then completely spurred posteriorly, or vice versa. It could be S-shaped. It could be, the septum could be completely straight, but the anterior septal angle can be just tilted to one side because of a fracture or trauma. So it's really important to assess where this thing is deviated, where their nose is blocked. I mean, ultimately, you want it to be as straight as possible so they can breathe out of both sides. But there are some general rules. General ear, nose, and throat doctors can do a septoplasty, which involves, it's really a submucous resection of the nasal septal cartilage, where you're removing a window of cartilage or bone from the nasal septum, and usually it's either discarded or crushed and put back into the pocket in between the flaps, leaving behind caudal and dorsal septal strut. Now, traditionally, it's 1.5 centimeters is the number that has been written, and that's the guide. It can be, it can vary how much you have to leave behind for the actual structural stability of the nose. Again, some people's septal cartilages are much softer, much more malleable, and you might need to leave more. Oftentimes, when we're putting spreader grafts, we're suturing them to the dorsal aspect of the nasal septum, and that will stabilize and give it some strength. So could you perhaps go under 1.5? Yeah, perhaps, especially if you're, again, augmenting the caudal septum. Having enough cartilage left behind is essential. Now, that's fine and good for deviations that are not involving the L strut. Then what do you do when it comes to the L strut? So there's a variety of techniques. You don't want to just, cut and remove it because you need that for the structure. So typically, it's a variety of suturing grafts to the nasal septum, sandwiching it between maybe two straight pieces of grafts, maybe weakening with some incisions, using clocking sutures or a variety of other sutures to kind of straighten out the parts of the septum that you can't just remove. Caudally, the septum sits on top of the nasal spine, and from an engineering perspective, this is a ball joint, which is you have this flat plate-like cartilage sitting on top of a ball, and it can rotate, tilt, and spin in all sorts of different directions if it's not stabilized. Oftentimes, the caudal septum is just sitting off of the spine to one side. So it's really important to make sure that the caudal septum is sitting on top of the spine in a straight fashion. It's secured there. If you do end up moving it, resecuring it to the nasal spine so it doesn't shift, usually with a permanent suture.
So do you do that before you do like a dorsal hump resection? Because if you do the dorsal hump first and then you fix that, then that can alter the height of and projection of the nose ultimately.
Typically, you want to remove the dorsal height of the nose, including cartilaginous septum, before you start harvesting cartilage, because if you harvest your cartilage window that you're going to use for grafting, and then you take height off, you might be left with less of a strut than you expected. So that's a general rule or general thought when it comes to that sort of thing. Additionally, you want the caudal septum that's sitting on top of the spine. You want that strong 1.5 or so bit that's doing the structural support to be sitting on top of the spine. It doesn't really do you much good if you have like 8 millimeters of septum protruding out beyond the spine, sitting on nothing, and only like 5 millimeters sitting on top of the spine. You really need a good, strong bit of cartilage situated on top of the spine. And again, this thing can kind of boat rudder on to either side if you're not careful, and it could require stabilizing grafts.
Got it. All right, and then next, what about nasal bones? A lot of traumas in Chicago, as you would imagine, so we see that a lot. Tell me about how you approach your osteotomies and what techniques you would use for what.
Yeah, so I mean, nasal bone fractures, you're going to, if they come in within like a 2-week window, you have the option of doing a closed reduction, either under local anesthesia. It is painful and you have to kind of counsel the patient, but in the right person, it can work. Or doing it under some sedation in the OR, which essentially just manipulates the nasal bones and tries to get them straighter. Doesn't work very well if you have like a saddle nose situation in an acute trauma. You have that at your disposal within the first 2 weeks, and it's almost worth trying to get the nasal bones to a straighter position. After that, you kind of have to wait about 2 months to see what the nose looks like with the swelling gone. Once the swelling has subsided, you can really see if there's any deviations. Importantly, when you're doing your initial assessment, you have to check for septal hematomas, septal fractures, drain any hematomas. That can chew up and melt the cartilage if you leave it there. So let's say now it's 2 months, patient comes in and their nose is just crooked from the bony trauma. You have to kind of do now procedure under anesthesia, most likely to straighten the bones. Now, unless you're talking about dorsal preservation rhinoplasty, which we're not, you have to basically do osteotomies to mobilize these bones. Depending on if you're taking a nasal hump down, you have to do something medially. So whether you're doing medial osteotomies or a hump reduction, leaving you with an open roof deformity, that will get the kind of medial aspect of the bones freed, and then some form of lateral osteotomies, and there's different varieties. High, low, low, high, low, high, basically referring to where you start the osteotomy and where you finish it. And that will mobilize the lateral aspect of the nasal bones and allow you to freely move those and fracture them out to the position you need. The idea behind the different lateral osteotomies coming in high and then staying low is that at the piriform aperture, you want the incision maybe to be above the insertion of the inferior turbinate, because if you are narrowing the nasal bridge, you don't want it to obstruct the nasal airway.
Are you a fan of percutaneous osteotomies?
Actually, for big deviations, I am. I think that percutaneous is great. I've noticed that it can cause maybe more swelling, maybe from just like the tunneling of the osteotome, but I think it's a nice way to have a controlled manipulation of a very deviated bone. Because you're doing perforations and you don't have this continuous osteotomy line, there's less of a chance of flailing of the bone, which gives you a little more control, especially when you may have to use slightly more force on a previously healed fracture.
Got it. All right, going on to one of the last points of obstruction, which you alluded to before, is in the nasopharynx, you might have a mass or something. Have you seen that? Is that like a zebra or?
Very rare. So, the risk factors, you want to make sure patient's not a smoker. Immunodeficiency is another one. So having large adenoids as an adult is very uncommon. So if there is a soft tissue abnormality there, it needs to be like worked up. And usually an otolaryngologist can handle that.
All right, well, we're almost there. I'm going to get you out on this. So open or closed rhino?
Depends. Everyone has their own rules. I don't think you can get the exposure and control with a closed rhino that you can get with an open rhinoplasty, especially when it comes to nasal tip. So nasal tip and also deviations of the big deviations of the mid vault. So for me, it's I will do closed usually if I'm mainly dealing with a hump reduction and an otherwise nice looking tip that doesn't need much manipulation. More than that, putting grafts in, delivering the tip, I mean, at that point it's difficult to kind of get the symmetry that you might want. Is there more swelling between the two? I think in the front end you might have a little more swelling, especially in the first week or two, but really they kind of become equivocal after several weeks. And the results, if you're getting a far better result in a difficult situation, I think it's warranted to get that person the best result possible.
Awesome. And one last thing, we didn't talk about dorsal preservation rhinoplasty, but we will talk about that in our next episode, so stay tuned. I'm curious what you have to say about that.
It's fascinating. It's a completely
so
different
hot right now.
It's a completely different way of doing rhinoplasty. Essentially, it's kind of like lowering a building by removing the first few floors and dropping it down rather than taking a few floors off the top. So it can be scary and it can lead to some instability if it's not done properly. So it is cool to see a lot of these results, though. It kind of like took off as its own wing and was being done for a long time, independent of this, and it's like almost like a half brother you didn't know you had.
Yeah.
Kind of just came back.
Welcome back, Dorsal Preservation. All right, well, thanks for tuning in. You can check us out on Instagram at the podcast and subscribe and follow us on for our next episode talking about dorsal preservation.